Good afternoon, everyone, and thanks for joining. What I would like to do in the next 15 minutes or so is tell you a little bit about what we are doing here at UT Southwestern and some reflections on what's happening nationally in terms of the impact of COVID-19 on some aspects of cancer care. I should perhaps start out by saying that, as you all know, this has been a very fast-moving situation, and many of us who are accustomed to having large amounts of data on which to base our decisions in taking care of cancer patients have found that this is a situation where the data are really only just emerging. So that I think you'll see as we go along, and certainly during the Q&A session that we're going to have later, that many of the questions that you have, we can provide part of the answer right now, but I think that we are going to look back on this time with a lot more information. And I make that point because we found ourselves having to adapt as new data comes out, and we share information with other cancer centers. And that's really been a key part of the strategy that we have used as we've gone through this. So what I would like to do over the next 15 minutes or so is cover a few topics. I'm going to start out with a very quick update of what the current COVID-19 status is in our part of the world here in Dallas-Fort Worth. I'm going to mention just a little bit about what we, in common with many other centers, are doing to make sure that our patients are safe and that our staff are safe within our cancer center facilities. I'll talk a little about what this has meant for the way that we work up cancer patients and our treatment. I'll say a little bit specifically about telehealth and the use of virtual platforms for care, because I think that's become a very big issue for us. A few words on the effect on cancer survivors, and then at the end I want to say a little bit about what I think this means for our future and for the future of the way we take care of cancer patients. So to start out with the current status in our part of the world, as of this morning, Dallas County has reported just over 2,600 confirmed cases of COVID-19. The number, for sure, the real number is higher than that. It partly relates to the testing status, as I'm sure you've been hearing on the media, but those are confirmed cases. And so far in Dallas County, there have been 64 deaths attributable to COVID-19. Within our healthcare system, the number of patients has actually been quite stable over the last few days. We clearly have not seen the kind of devastating surge and number of cases that other parts of the country have seen, especially in New York. At the moment, there's cautious optimism that we may not see an enormous surge in the same way that they did, although we do anticipate that we will continue to see folks affected by COVID-19 in this area, probably for many weeks or even months to come, although it may be at a relatively low level. When we're thinking about the management of cancer patients with COVID-19, we've really had to rely a lot so far on data that's emerged from Wuhan in China. The cases in the US, as you know, started predominantly in Washington state before arriving in New York. At the moment, the amount of data we have that's specific to cancer patients from those centers is relatively small. What we know so far is that it does appear from the information that's come out of Wuhan that cancer patients have an elevated risk of developing COVID-19. And as far as we can tell, that elevated risk is about twice the normal population. So that a patient who has active cancer and is having treatment for cancer probably has a higher risk of developing COVID-19. If they do develop COVID-19, as far as we can tell, again, the risk that that will require support on an intensive care unit is also higher. And that risk appears to be elevated to somewhere around 3 to 4 times the risk in the normal population. But again, at the moment, because the numbers are relatively unreliable from China, it's difficult for us to say with certainty whether that represents the true magnitude of the increase in the risk. Moving on to steps that we're taking to ensure the safety of our patients and also of our staff within the cancer center, I would say that some of the measures that we've taken here are very similar to those that have been taken in many other cancer centers across the country. And we've been comparing notes through our professional societies, through web-based platforms, through direct one-on-one conversations with other cancer center leadership. And we've all really gravitated to a very similar set of precautions. The best precaution of all in terms of protecting our patients and limiting their exposure is for them to stay at home whenever possible. So as you've heard many, many times now through many media outlets, social distancing, remaining at home as much as possible on lockdown is undoubtedly for those who don't need to come to our facility against COVID-19 simply by reducing exposure. We understand that there are many of our patients who still need to come to the facility, and I'll talk a little bit about that in a moment. For those folks who do need to come here, we do have a number of measures in place, again, very similar to other centers. So patients who come in through our door, and we have limited the number of entrances to the facilities, are screened. There are some screening questions about their recent travel and exposure. They have a temperature check. If they screen positive, in other words, if any of those answers are positive, somebody has traveled, then we have a procedure in place for how to deal with that patient, how to help them and get them to testing if that's what's required. We undertake the same process for our staff so that they go through the exact same screening. I go through the exact same screening every morning when I come into the building. And the purpose of all of this is because, as you will have heard, many people who are carrying the virus do not have symptoms. And so we make sure to go through this screening process every day. Additionally, and just recently, to limit the number of people in our building, we've asked that visitors, caregivers, do not attend an appointment with the patient. We've put measures in place to make sure that they can remain in touch with each other during a clinic visit here when a patient needs to come. But as far as possible, again, we're minimizing the number of folks coming into the building. For those patients who do test positive but have to come to our building, which is a relatively small number, we've designated specific pathways for how those patients come in, the elevators that they take, the areas within our clinic space that they occupy, to make sure that we keep those folks isolated so that other patients and staff in the building do not have exposures as a result of that. So we're taking great care to make sure that anyone who's coming into our buildings is safe, and that includes our staff. In terms of what this has meant for the treatment of our patients, this is a complicated issue, and what we have to balance with every person who comes into the building is the risk of disrupting their cancer treatment in any way against the risk of them developing COVID-19 and the consequences that they may suffer as a result of that. And so, again, in common with many other systems, the way that we have looked upon this is by thinking of different kind of sets of situations for our cancer patients. As an example, we have many patients who come to visit for follow-ups who are not on active treatments right now. And for those folks who are not on active treatment, or even some of those who are on a standard hormonal type treatment that they have been on for many months, the message is, if you are well, with no symptoms, tolerating your treatment, doing fine, we will contact you by phone, and we will see you once we begin to reopen our doors and get back to normal. But the benefits to those patients of coming to the hospital are far outweighed by the risk of developing COVID-19 if they come. So in that group, we've made a decision to hold appointments and have those folks visit at the end of the pandemic. There are then two groups of patients where we need to decide whether to hold or delay treatments. In some of those patients, the decision to do that is marginal, and the risk-benefit analysis of whether we should hold treatment or treat those patients can be a pretty tricky one. But what we've tried to do, wherever possible, is contact those patients through telehealth, evaluate them that way, and then we'll make decisions from patient to patient as to whether it is safer for them to come to the building and get their treatments, or whether it will be better for us to delay their treatment for a period of time, or perhaps stretch out treatment. So for many people who may be on, let's say, prolonged maintenance treatments that they receive once every 4 weeks, for now, we're looking at the possibility of extending that to maybe once every 6 weeks or something similar, so that we can simply reduce the number of visits they make to us and then the amount of time they need to spend in the hospital.
As for cancer screening, something I've spent the last 20 years of my life promoting with the ACS, it was with quite a bit of consternation that the ACS came to the conclusion that we can't screen right now for most cancers, but it is definitely the right decision. And so our recommendation is that screening examinations should be postponed, at least the majority of screening exams. The one exception or possible exception is that of colorectal cancer, because there are screening options for colorectal cancer that don't require an in-person visit anywhere, screening options that you can actually utilize at home. These being stool tests. There are various forms of stool tests that are available and are effective and have been recommended by the American Cancer Society and Preventive Services Task Force and other organizations for many years. The uptake has been relatively low in the US, and we wonder whether or not this COVID pandemic is going to lead to some shift in that. There are honestly some concerns about stool testing. There are a number of reports about COVID-19 actually being shed in the stool, but there are questions about the viability of the vaccine that's found in stool and whether it truly represents a significant infection issue. But at any rate, other kinds of screening exams are off the table for now, but it's very important that you keep track. So if you are due for your annual mammogram, or if you're due for your breast cancer screening, or if you're a smoker and you've been told that lung cancer screening should be initiated, this is not a time to say, oh, never mind, I will wait till next year. So as soon as we begin to come out from under the constraints posed by the pandemic, you need to get in touch with your providers and try to get back on track with your scheduled or required screenings. Of course, avoiding tobacco is one of the best things you can do for yourself, both from a cancer risk and overall health risk standpoint. So certainly if you don't smoke, don't use this opportunity of sitting around at home to start smoking. If you do use tobacco, there are a wide variety of resources available to help you stop. There is some evidence that smokers may have worse outcomes if they're infected with COVID-19. There are some questionable associations that smokers may actually be at higher risk of being infected. That the data around that is still relatively early and sparse, but we do know that for other kinds of viral infections that the risk is increased. So it is a reasonable hypothesis that smoking potentially worsens your risk and potentially worsens outcomes. Obesity, again, is a major risk factor for cancer and a variety of other health conditions, and maintaining a healthy body weight is important. If you are already overweight or obese, making a plan for how you're going to change that is really important. There are counseling and caloric restrictions can be helpful, and adding in physical activity is also extremely helpful. With regard to your diet, there are a number of different dietary factors that worsen your risk for cancer, and consequently making some shifts in your diet to really emphasizing plant-based foods, fruits, grains, vegetables, lowering your intake of red meat and processed meat, eating more fish and poultry. If you're going to do dairy, low-fat dairy, and trying to avoid trans fats, and trying to avoid sugar. There are a lot of different resources online that can help you come up with some, I know we can't go to the gym right now, but you can do a lot of very basic things at home. This gentleman is doing jug swings. He just filled up a gallon jug with some sort of blue liquid, I think, just to make a pretty picture. But there are a lot of things that you can do. I found this particular website to show a variety of exercises you can do right there in your living room using your couch and the jugs like this and other sort of props to help you get that same level of workout that you might get in a gym. And then just going outside, walking, depending on your neighborhood, it may be a good time to do that. I certainly have seen a lot more walkers in my neighborhood over the last month than I probably did in the 5 years preceding this. But also simple things like dancing. Just turn on some music and spend 15 minutes dancing in your living room. All of that counts. All of that can help lower your risk of a variety of health issues. And again, in addition to that, there are a wealth of free workout aids that you can find online. If you're going to drink, make sure you do so in moderation, and that means no more than, on average, 2 drinks a day for men and 1 drink a day for women. Be very attentive to your behaviors. Now that you're sitting home all day, there might be a tendency to start drinking a little earlier in the day, to drink more heavily than you might otherwise. You don't have to get up and go anywhere tomorrow. So be very aware when you sit down and have a drink, and don't let it become a habit that you are really not attentive to. Also, in particular, if you recognize that you're anxious or you are depressed, and your first impulse is to turn to a bottle of alcohol, recognize that that is how people can get in a lot of trouble. So think about other ways to address some of that anxiety, other ways to fill the time. And heaven knows I've got a host of self-improvement projects around my house that I've been planning to get to. And now I've got that time that I never had before that I can get to. Calling a friend, reading a book, cooking a meal. Find some healthier outlets than simply drowning your sorrows, anxiety, or boredom in booze. And invest in your overall emotional well-being. It's really important. The rates of depression and anxiety appear to be shooting up around the country as we are in this very uncomfortable situation with no clear end in sight. And we are limited very much in terms of our contact with other individuals in ways that for most of us have never occurred. So recognizing that it is normal actually to have some periods of depression, have some periods of anxiety, but figure out ways to address these, in part just by recognizing that social distancing doesn't mean social isolation. So still reaching out to friends, colleagues, talking to people on the phone or video chats, all of those sorts of things. And then again, a host of resources are available to you online. And I believe I have come to the end of my formal remarks, and I'm going to turn it back over to Dr. Tidrow.
Thank you, Dr. Sweetenham and Dr. Brooks, for giving us overview, both from the perspective of what cancer patients and their families need to be thinking about during active treatment and survivorship, as well as what we, others who are healthy and trying to prevent both exposure to COVID and cancer development and risk of cancer. We have had, as I mentioned earlier, a lot of questions. And I want to just start us off, and asking, John, can you talk a little bit about, for the patients who contract COVID-19, what is their impact on patient care? You talked about they get routed differently, but what should they be thinking about in terms of how their care is impacted?
Yeah, so I mean, it's a very important question, and because we know that a cancer patient who, excuse me, is COVID-19 positive has an elevated risk of getting very sick from particularly if they require cancer treatment. Clearly we make decisions about how we're going to manage that situation on an individual basis, but the judgment that we need to make is, in many ways, it's a very simple one at the level of the question we need to ask. And the question we need to ask for each of those patients is the risk of going ahead with a cancer treatment and putting the patient at elevated risk from their COVID-19, is that risk going to be higher than the risk of delaying treatment until such time as they've cleared the virus, and then getting ahead with treatment once the virus is cleared? For the most part, with a few exceptions, we would take the second of those alternatives, so that if someone tests positive for COVID-19, if it's going in our, if we all agree, including the patient, we'd obviously involve the patient in that decision. But if we're all agreed that it would be safer to hold treatment until the patient has recovered from the COVID-19 and cleared the virus, then that is what will be our goal. Now, there are rare circumstances where we just can't wait and a patient has to be treated right away because of their medical condition. And in that case, there are things that we can do in terms of boosting blood counts and helping to boost immunity that will give some protection. But wherever possible, the safest approach is to wait and resume the treatment as soon as the virus is gone.
Thank you. A lot of the other questions stemmed around how caregivers and family members and household members can protect cancer patients during the pandemic. And, we talked about social distancing earlier, but one of the questions was very interesting in terms of whether their caregiver or household member works as a healthcare professional, first responder, or frontline worker. What should they be thinking about, especially when their job puts them at higher risk for COVID exposure?
Yeah, I mean, again, as I said right at the beginning, I think we're still learning about this. I mean, one thing, for example, that many organizations are doing, ourselves included, is that if healthcare workers have concerns about putting their family at risk, they are providing the ability for healthcare workers to stay in hotels, which is obviously not what we really want to do. We don't want to split up families, but if that's a real concern, then that option is available. Apart from that, though, there isn't really hard evidence right now to suggest that healthcare workers who are going into screened environments, taking care of these patients, wearing PPE, and so on, we don't have strong evidence right now that those healthcare workers are taking the virus home with them and infecting other family members. We certainly, I'm not aware of much evidence to suggest that. So I think really, you know, the precautions are the same as they would be in any other situation. It's limiting contact in as much as you can in a family context. But if people are going to be reassured or have their minds put at ease by, you know, avoiding family contact, then certainly a number of employers are giving them the ability to do that.
Great. Dr. Brooks, you talked a lot about the perspective of self-management of behaviors, and some of the questions that have come in are about how families and households should approach if they're concerned about other members in their household struggling with behaviors. What would you recommend for those concerned household members in connecting and communicating with their loved ones?
That's a really good question, and it's a fine balance because it's not as if you all are having big disagreements that you can just walk out and go somewhere else in many instances. I think that one of the most important things that we can do is model the kind of behavior that we're trying to reinforce in our family members. So modeling eating healthy meals. And if you've got responsibility, or if you're rotating responsibility for cooking, for instance, making sure that you are cooking the kind of meals that I discussed, modeling appropriate alcohol use, or potentially even considering taking a holiday from alcohol as opposed to joining them and having that after dinner glass of wine that turns into 5 or 6 glasses for them when you stop after one. I think that it's pretty clear that we can usually not harass and harangue other adults into making major changes in their behavior. We can certainly express our concern if we feel that we're seeing behaviors that that makes us worry about them, but put it in the context of, I'm very concerned when I see you do this. This is how it makes me feel. So not blaming them, but helping them understand that their behavior is potentially having some negative implications or impact on you. Again, very challenging, but I think that there are ways that you can approach this and not lead to World War III in your household.
Yes. So we did mention earlier, and you mentioned both that COVID-19 smokers are at higher risk. And we talked about, and I just want to acknowledge that what you will be receiving at the end of this webinar are resources that you can connect both cancer survivors as well as healthy individuals with smoking cessation resources if they are struggling to stop or make an cessation attempt. And that will go out to all webinar participants at the end of this call. So is there anything else that we want to emphasize to those folks other than it's great to be motivated to make an attempt, and that there are several resources even in this time of social distancing that are available to them?
I think that's the main point. I would say that the evidence around vaping is frankly less clear than that around combustible tobacco products. But as John mentioned earlier, this is a new disease for us, and we are, learning something new every day. The primary issue, again, is if you don't smoke, don't use this as an opportunity to start. And if you do smoke, take advantage of the various resources that are out there and available to you.
Great. I want to turn over to the Q&A. There was a couple of questions that came in about the fact that you can do home-based colorectal cancer screening. Mm-hmm. But then the question is, what if that test is abnormal? And should you be delaying your diagnostic colonoscopy and issues related to symptomatic symptoms and how to manage receipt of not screening tests, but diagnostic tests? Should
Sure.
those also be delayed during this pandemic?
I think that most health centers are limiting procedures like colonoscopy or other kinds of procedures to only those patients in whom their symptoms or their presentation would suggest a potentially life-threatening condition. So having some blood in your stool and being concerned about it is certainly very reasonable, but that is not a reason that you need to run right away to the emergency room or anticipate that you're going to need to get a colonoscopy right away. You certainly would want to keep track of that, make your healthcare provider aware of that, and make sure that, again, when we start resuming something more approaching normal activities, that you are prioritized and higher on the list to get that done. With regard to screening for colorectal cancer using stool tests, that is a big concern, and I think that providers should have that conversation with their patient when they are making that recommendation. Well, it's time for your screening, and stool testing is a reasonable option. However, if that test is positive, you're going to need a colonoscopy, which you may not be able to get now or for the next month or two. It's important to recognize that there have been some studies now that demonstrate that delays of 6 to 8 weeks, even 2 to 3 months, don't seem to make a big difference in outcomes. So if you have a positive stool test finding and you're not able to get a colonoscopy completed for even 3 months, it doesn't appear that increases your likelihood of having a more severe type of cancer or worse outcomes. So while certainly that is not going to necessarily help you sleep a whole lot better at night, hopefully it'll at least alleviate some of the anxiety and fear that might come along with that.
Thank you. So a lot of the questions that we received are very specific to particular types of cancers, in part because cancer is a very complex set of diseases and really can't be treated with a one-size-all-fits approach. John, in terms of the data that we have available to us, are there particular cancers that put individuals at higher risk for COVID-19 or should be particularly worried, or particular treatments that they are currently exposed to that should be, very vigilant in their activities?
Yeah, so, we don't know that for sure at the moment, Jasmine. We know that patients with cancer in general probably have a somewhat elevated risk, and that if you're having a treatment for cancer, that risk is higher. So, with that information, we make the assumption that if you have a cancer or a treatment which really profoundly affects your immunity, then we're making the assumption that those patients are probably at the highest risk. And so, for example, patients with blood cancers such as leukemias or some lymph node cancers, lymphomas, where we know that those have the potential to make patients very immune suppressed, we're making the assumption that those patients are more at risk. And similarly, patients who need very intensive cancer treatments, especially bone marrow transplants, some of the new treatments like CAR T-cell therapy, again, we make the assumption they're at high risk, and for the most part have actually decided to delay most of those treatments until we're through the worst of the pandemic.
One of the Q&A questions that recently came in is, we've been hearing a lot about asymptomatic presentation and trying to get a handle on how many people are asymptomatic. How does that affect your screening process when beyond their travel history and whether they have fever? And what should we be thinking about, given that we know that there's a lot of asymptomatic potential transmission going on?
Yeah, so at the moment, our screening, most cancer center screening, is based on the, two things. First of all, we're looking for known risk factors, contact with someone who's had the condition, overseas travel, or that's not an issue now, but travel in general. And we're checking temperatures on folks as they come through the door. Beyond that, what we are doing now is, because we know that asymptomatic folks can carry the disease, everybody who comes into our building now wears a mask when they're in a clinical area. But it's obviously at the moment, it's very difficult for us to know how many people are coming into the building who are asymptomatic but have the virus. And we're not going to know that with any certainty until testing of asymptomatic people is much more widespread than it is now.
And with the potential for antibody testing, how should people think about antibody testing and where we are in the process of that affecting decision making?
Yeah, so again, I sound like a broken record, because again, the answer is we don't really know for sure. There are a number of antibody tests emerging right now. And my understanding, I'm not an infectious diseases doctor, but I understand that one or two of those that are likely to become available very soon are much more reliable. There have been a number out there so far that have not been very reliable. But I think that once we know whether somebody has antibodies or not, it may be quite a while before we know whether those antibodies are protective against reinfection. So, I'd love to say, in 3 weeks from now, we're going to have an antibody test and we'll be home and dry. I don't think that's the reality. I think that we're going to be on a learning process about antibody testing and immunity probably for several months.
I do want to get back to the perspectives of cancer patients who are now in the survivorship phase. And there's been questions about, how at risk am I depending upon how long ago I completed my active treatment, like chemo or immunotherapy. Does my immune system behave like someone who doesn't have cancer and never had cancer treatment in relation to COVID? Or how should cancer survivors and whether time since being in active treatment affect their decision making?
So for most patients, there's no magic time point at which you can say immunity has returned to normal. But as a general principle, with a few exceptions like bone marrow transplantation, the further you are away from your cancer treatment, the more likely it is that your immunity has been restored to normal. Now, at 1 year from the end of treatment, I would make the assumption in that situation that someone in that situation could still be at some elevated risk from COVID-19. At 5 years, again, it would depend a little on the treatment. I would make the assumption, though, that their immunity to a virus like this is likely close to the normal population. But again, my heavy disclaimer there would be that we don't have hard data to support that yet.
There have been a lot of news stories and a recent QA question, I'm going to take one more, about the high number of COVID-19 deaths in African Americans. Would either of you like to speak to why that might be happening and what we should be focusing on in trying to prevent deaths from COVID?
Well, I'll start, and I would say that it is sadly not surprising to me, because I think it's reflective of the underlying issue of disparate health and disparate health care across the U.S. for African Americans, Hispanics, other minority, and impoverished folks. And the basic issue is that if you are in a situation where you already have higher rates of cardiovascular disease, higher rates of diabetes, some of these conditions that we know are predecessors or help increase the likelihood of developing COVID, and you have lower risk of receiving good health care, that's a magic elixir for having disease spread very dramatically. Add to that the fact that people who are in these essential jobs, largely service jobs, have continued to have to go to their workplace. They don't have the advantage that I have of being able to sit home. So they are out being exposing their friends and neighbors, potentially carrying the virus back asymptomatically into their households. And they also are oftentimes living in more cramped spaces and environments. So there are a lot of different reasons that have nothing to do with race. It really has much more to do with the societal place that many of these individuals find themselves.
Thank you. I am conscious of the time, and in thanking, please join me in thanking our speakers, and thank you so much for submitting such interesting questions. We hope you learned something from this webinar. It will be recorded and shared with those so that you can share it with your friends and family members. We're also planning future cancer-focused webinars during this coronavirus pandemic. And please take the time to fill out this poll as well as the survey we'll be sending out to you later today so that we can tailor future webinars to your educational needs. Again, I want to thank the speakers for taking the time to orient us to what we can do to protect ourselves and our loved ones during this unprecedented time. And I hope you all stay safe and well.